Hi, good afternoon. My name is Professor Stacy Sanborn, teaching N410, and today we're going to talk about pediatric special issues, specifically cleft lip and palate and failure to thrive. Start off with this little picture here of this guy who doesn't seem to be too amused. I share with you that the first time I saw a baby with a cleft palate, I was working as a student nurse intern in the newborn nursery, and it was something that I would never forget. I'm pretty sure, my mouth dropped open, and I was just so taken back by it. Um, and I can't help to think that it was um, somebody, if was in the nursery, was with other nurses, would probably have read the shock on my face and not been too pleased with it. Something I've learned to work on throughout the years. But I never forgot that image and how upsetting it was. And I do feel that the mom with this particular baby was having difficulties bonding as well, which we're going to talk about in a minute. But I'm here to tell you that it has a great prognosis, and through surgery, there can be so much improvement cosmetically. It just takes a little bit of time to get over the initial acceptance. If there's, safe to say, getting over it or through it, as well as working on feeding, growth, and development. In this example here, this is an older child who has not had a correction. The child looks very happy, looks like is developing pretty well from this image, um, but who's to say? If you would like to follow along on your textbook, you're going to use Wong's page. We'll start on page 245 to 309. So if you didn't know, surprisingly enough, cleft lip with or without a palate is one of the more common birth defects in the U.S., and it occurs about 1 to every 600 births. You can go to a table that compares the difference between a cleft lip and cleft palate, but I have a image in the next slide to share with you. What causes it can be a combination of genetic and environmental factors, and so oftentimes you will see the genetic component where it runs in families and certain races. What we've learned is that folic acid supplementation can protect against cleft palates, and so ideally all women of childbearing age would be receiving adequate folic acid supplementation to prevent this type of defect. Those with a history may require more folic acid if there's a family history of cleft lip or palate. So I'll type there. So I'll start here. I remember watching a documentary in 2008. It was an Academy Award-winning film about this little girl named Pinky and describing her life and how difficult it was for her in her country to have a cleft lip and palate, and how she was so socially isolated, and so through I think it was Operation Smile, she was able to receive a surgery, and it just kind of chronicled the family's ordeal with that. And as you can see, her life quite changed by it, and she went to the academy and things went really well. It was a very hope-inspiring type of movie. And when you look at these images of baby right here, A, B, C, and D, is you'll see here is that uh, you can have a cleft palate without a cleft lip, right? So if you were to look at this infant, you wouldn't think anything. You see here, this baby has in C a bilateral cleft lip and palate. In B, it's a unilateral, so it's only on one side and includes both a hard and soft palate. And then in A, it is an example of a cleft lip without palate. So it's pretty obvious to make the diagnosis without any additional imaging by just the visual examination. But you will find that when you were in the newborn nursery, as part of your newborn assessment, as you're going with a gloved finger, insert your finger into the baby's mouth, not only checking for the suck reflex, but you're going to see if there's any palate involvement as well, because it can be very, you might miss it. Um, Palates, the palate develops at different developmental stages, and I'm not going to test you on that. Just be aware it happens very early on. Parents will always ask you, when did it happen? Was there something that could have been done to prevent it? And if you want to share with them that information, that it happens so early on that sometimes families don't even know, like, what was happening in the lives of the woman prenatally. Let's see here. It obviously impacts the feeding. Many can swallow normally, but it may be difficult to get a good seal like with breastfeeding or bottle feeding. And so we'll show you in a slide that there are adaptive types of devices to help with feeding. Once a diagnosis has been made, the family is going to receive a full team of care, including plastic surgeons. We worked with ear, nose, and throat. We have orthodontics coming in, a speech and language pathologist, audiology, because there can be involvement with the ears, pediatric, social work, psychology, and many more. The repair for the lip occurs early on. I've cared for infants between 3 to 6 months who've had their lip repaired, and I really enjoy that age very much so, but it's a much simpler procedure. Whereas the cleft palate happens a little bit later on. I have a slide to show you that, and that happens up 6 to 12 months, if not even more later on. For that child in the film, she was much older when she had it. Now, when the families have their baby, sometimes there can be a lot of grief around this, and that is the loss of a perfect child, just accepting the physical differences. So we really want to, encourage them as much as you want to say, I saw a movie and it's going to be all good, just wait and see. Let them have that expression of their grief. Let them be sad, and that may help them work through that expression. There's probably a lot of feelings going on. Who's to say? Guilt, shame, such loss. Only know by inquiring, but let the families express themselves. Feeding may be a challenge, and this is where it really comes in helpful with a nurse with experience, working with lactation consultant to help the families learn how to feed their babies. And again, we'll have some devices to show. Now, key thing here, probably really important for you to pay attention to, is what is your post-surgical care going to be? So in these babies, we're going to avoid putting them in the prone position. We really do not want them touching that suture line at all. They're a little fussy, as you could imagine, having a surgery. So we're going to be doing pain management around the clock, and then PRN. I found it common for these children to actually receive a steroid IV to keep the inflammation down. That will help with those ABCs of airway, breathing. And also we're going to be looking for any type of excessive bleeding. We shouldn't have any bleeding post-surgery if the sutures are intact, so that's where you're going to assess for that. There probably will be a little bit of blood swallowed, and it wouldn't be uncommon to see a little bit come up, but we wouldn't want to see any active bleeding. As a nurse, you're going to be assessing that suture line to make sure that the wound edges are approximated, that the sutures are intact. You're going to be paying attention to both local and systemic signs of infection. So looking around, there's going to be inflammation, as you can imagine, but any signs of changes. I mean, babies especially do not localize infections well, so paying attention to temperature, changes in behavior, level of consciousness. We encourage the use of cups, believe it or not. Even in a very young infant, they can take from a cup. We want to avoid spoons. We want to avoid hard syringes, like putting that medicine directly in the mouth, where it may need to be very careful. You don't want to disrupt that incision. And then we use a type of elbow restraints called no-nos. N-O-N-O, and they are bilateral. They look like arm boards. They are quite an interesting contraption because they have Velcro, so they're soft. They're like a soft restraint, but that will help to prevent the baby from grabbing at their mouth. Also, if they're younger, you can swaddle them and position them on their sides so that they are not able to access the suture line. Key thing. Here's a photo just to show. This is a much older, this is probably an adult, and I can tell by looking at the child's, the teeth. The teeth are low, and you can see this is unilateral. It goes all the way back, soft and hard palate. As you can imagine, if you had this type of defect, could it affect your sinus cavities, your nasal? Absolutely. So these children are going to be at greater risk for sinus infection, as well as you can see problems with the eustachian tube, and so oftentimes our surgeons would even put tubes in the ears known as pressure equalization tubes, so and give them eardrops. There's just all together, sort of connected and at risk for different types of infections. And then, of course, this right here, and this person had a significant amount of caries or dental decay, what we call here as cavities. Had to include a picture. Saw this during my orientation as a nurse. So this is what the surgery looks like. So that is quite extensive. I would imagine significant amount of pain, and then they sutured up. I don't know all the intricacies of what that surgery looks like, but obviously we've got this going on here. So remembering that, yes, they're probably going to be a little bit of bleeding that was aspirated, some pain. A picture is worth 1,000 words. And this is to show you different types of feeding devices. So this is going to be key because babies are doing so much rapid growth that we want to ensure that they are getting adequate nutrition. So here are some of the older vintage type of feeding devices, and these are newer. Haberman feeder, a pigeon feeder, and what usually is going to happen is the nipple is going to be quite elongated, and it that doesn't have the baby doesn't have to work so hard to really have that firm suction. It's sort of more of a drip. Here is a squeeze bottle, for example. And then we had to finish this off. This is an older, looks like an older types of surgery. I've not seen this device used, this plate here, but what I do see, if this is my patient, I was caring for them post-operatively, is I see a well-hydrated a patient that does not look like they are in any type of discomfort at the moment. The mucous membranes are moist, there's drooling, the wound is healing quite nicely there. Baby looks like they're in a caregiver's arms and they're comfortable, so I'm liking what I'm seeing right here. And of course I would assess vitals, and I would assess for pain, and I would assess intake as well as output. Okay, hopping on over here next to failure to thrive. Had to use a photo, found something online. This is it's pretty graphic, right? And I don't like what I'm seeing actually at all. And I'm looking at the baby's buttocks, and it looks like there's some skin breakdown, very thin. You can see the bones. So this is a very unfortunate example of failure to thrive. Also want to show you here, students, is that different types of growth charts. That's why getting weight, height, and head circumference is so important in that first year of life during our wellness, is because what we want to see is how is the baby growing. I'm going to work over here on this slide, and if you see the child in foster care, it looks like they were following their growth curve nicely, and then something happened where it started to plateau, and it started to drop off where it was below the 5th percentile. And also what it's showing here in this one slide is that child was placed in foster care and then was able to gain that weight back. And the other chart that's mostly blue, it's a boy's weight. You see that the weight velocity just drops off and it starts to plateau, and there's really minimal growth. So the baby has gone from looks like a 25 percentile to the 5th percentile. So that's why it's key. This is objective data that helps us to put the picture together. Adding this in, this was in the text, found this elsewhere, but a majority of the failure to thrive is non-organic, okay? So there's no known cause of it. It's really, and that's what I always thought it to be as a newer pediatric nurse, is that most of them were failure to thrive because not of some type of problem with absorption, but they were just not they were neglected. And neglect is a #1 cause of child abuse. It's not physical, this is for another chapter, but it is a #1 cause of child abuse is neglect. It could be stimulus deprivation, a little bit of both. And so we're going to go here. And most children are going to present in infancy before the age of 18 months. Now this is right out of your text. So how you want to remember it is the organic failure to thrive, which is a result of a disease condition. So this is the minority of cases, whereas the non-organic failure to thrive has no apparent physical cause. Not always easy to tell though. The child's going to have a full workup so that we do not jump to conclusions. Miss anything. This is kind of hard to see, but there are a variety of causes, and so again, is not enough food offered, incorrect formula, is that due to a disease process, or is that because they're not getting enough caloric intake? Too little food. Now in the health problem slide, that is something involving a digestive system, so that is going to be more organic in nature. food intolerance, issues with metabolism is organic in nature. Infection, organic. So again, a lot of things have to be considered in the workup. And then over here, another example of inadequate caloric intake. And so in some cases, there might be access to formula, neglect, poverty. I've seen families water down formula to make it stretch. They run out. It could be due to behavioral issues with the child refusing to eat. That tends to be a little bit more complex in nature. Then the inadequate absorption is more organic. So for example, like a child with cystic fibrosis, this child lacks the enzymes to digest food and fats, so they need to have medications for that. In that case, we can give them adequate calories, but they're not absorbing it. And also because of the disease process with cystic fibrosis, they may be using a high amount of calories. Coming over here to this slide. Increased metabolism. So in some disease process like hyperthyroidism, burning up a lot of calories. Congenital heart defects, using a lot of calories, and they tire so easily, so they don't even usually finish feeds. I'd worked with children in a burn hospital. By virtue of wound healing in a hypermetabolic state, these children could not eat enough food when they were ready, so they often would have feeding tubes to give them the extra calories that they need. And then this is another example. So this one's more of a multifactorial. This little guy right here, you see obviously a large scar, you see a colostomy bag. This is an example of a child with Hirschsprung's disease, where they have a disease part of their intestine. It's not innervative, it has no function, and the surgeons will cut that out and anastomose the parts of the intestine that work. So in this case, a child, even though they're given adequate calories, they're not able to absorb all of that. And so what I also notice is child has a feeding tube and maybe receiving some sort of TPN to help make their calories for growth. Okay. The diagnosis of failure to thrive is made from evidence of growth failure, and their weight is below the 5th percentile. So what are we going to do about it? So oftentimes when these children are admitted, they are going to be on a strict calorie count. They're going to have, before there's going to be some dietary history involved. Family patterns, how they're preparing food, what does that look like? Are there any allergies? Running tox screens, sensitivities to food. And then the management is key, is reverse the cause, right? So if it's obviously neglect, then we're going to reverse that by not neglecting the child and giving them not only the calories they're going to need for current growth, but maybe some catch-up calories as well. If they are having issues like through not getting the medications or the treatment for their cystic fibrosis, then they will get that. So reversing the cause and giving additional calories. And this is where we call in our pediatric dietitian, who I've always enjoyed working with. I don't think I've ever met one that I didn't like, who are so dedicated to ensuring these children receive the nutrition that they need. And so in those little kiddos that I work with, we didn't just give them free water usually. We always wanted to give them, we had these high calorie protein drinks. So they were like fruit flavored, I think like Gatorade, but they had protein added to them. They received lots of nutrients, vitamins, and in their feeding tubes or in their Ensure. But one thing to think about, if this isn't treated, not only is the child not going to grow in their weight, their failure to thrive, they're not going to reach their full potential with their height, and then later on it could actually affect their brain development, right? And so you're going to see first the weight will drop off, then on the growth charts the length or height, and then head circumference. It can have some obviously long-term effect on the child. So nursing considerations, we're always going to ask ourselves, what can we do about it, right? So we learned in management, reverse the causes and do those things that support that, as well as ensuring the child is receiving adequate calories. If they're on tube feeds, you want to make sure you don't pause that at all, if at all possible, unless maybe they're reclining flat. But all of those calories have been calculated for them. It can be very challenging because sometimes these children who have neglected, it's not, I can give them the calories and I can give them the meds, but they may have fearful of caregivers, they may be mistrusting, they may be irritable, so they can present some challenges. And so I ask you is, how does a nurse use a therapeutic relationship in providing care for the child and family? Something to think about. Ideally, the child will be assigned a primary care nurse. And so it would be the same team of nurses working with the child and the family. We have to kind of go back to Erickson's. What are we learning in the first year of life? Trust versus mistrust, right? So if they've been neglected, we want to be sure that we're providing consistent caregiving, consistent with the rules, established feeding times, have a sitter if somebody can't be there with them. This is from another source, but here are some nursing diagnoses that you would think about. You think about anybody who'd be malnourished is right. So inadequate nutrition, deficient fluid volumes, maybe impaired urinary elimination. And so what are you going to do about it? Once you start thinking like that, you can think like a nurse and you know that, hey, imbalanced nutrition means I'm going to give them balanced nutrition. If they're constipated, I'm going to increase their fluids and give them medications for that. Increase their fiber. If they have that skin breakdown or what we saw in that very first photo of that baby due to probably inadequate vitamin intake or deficiencies, then we're going to correct that as well. And then I hear lastly, impaired parenting related to lack of knowledge, right? Sometimes the families need help. I've had non-English speakers who did not know how to prepare formula properly. If it's something as simple as that, or maybe they heard from somebody that it was okay to give excess water. And so there's just so much information to be obtained, and then you can base your care on that. And that is it for Failure to Thrive. If you have any questions, please don't hesitate to reach out to me. Thank you.